Hello, everyone, and welcome to another episode of ACE Podcast. We are very excited to have you join us today. It's not the first one. We've had series of conversations where we've discussed, of course, maternal and newborn health with emphasis so far on maternal, the mother. We've discussed the mother, we've discussed her journey, and we've discussed about the systems surrounding her care. But today, we want to go a bit further, right? And discuss the newborn. The baby is not and cannot be separate from the mother, right? They all make up the continuum. And that's why we're here to discuss the newborn component today. And to join me in that conversation, I have two very amazing personalities with me here in the studio, and I will be introducing them shortly. To my left, I have Dr. Bolaji. Dr. Bolaji is the Executive Director of CeNHRI, the Center for Newborn Health, and she's also an experienced consultant pediatrician, and we have her with us today. We're excited to have you with us today, Dr. Bolaji.
Thank you very much, Billy. Thank you for inviting me. I'm happy to be here.
I am excited to have you join us today. And to my right, I have Dr. Aisha. Dr. Aisha is a technical advisor right here at ACE Group, and she's also a consultant pediatrician. We're excited to have you with us, Dr. Aisha.
Thank you very much, Billy. I'm glad to be here.
Thank you. So we have Dr. Bolaji and we have Dr. Aisha, and we look forward to all of the exciting knowledge that is going to be shared by them with us today. So we're going to get right into it, right? I already did a brief background and talked about the fact that we're focusing on the newborn component today. We've discussed maternal. If you haven't watched any of our episodes that discuss the mother, please go back, stream all of the previous episodes, drop comments, right? And then share it to colleagues, friends, families. We want to keep the conversation rolling because now we're expanding. We're getting to talk about the baby, right? Just as we emphasize that a lot of maternal deaths are very preventable, same as the baby. Currently, according to World Bank data, right, the most recent World Bank data, neonatal mortality sits at about 39 deaths per 1,000 live births. And we want to pull down that number. And these deaths are very preventable. We know what is causing the deaths. There are solutions that have been put out there. However, are these solutions, these things that are working, really translating on the ground, right? It's bridging that gap between the science and all of the things that we know and what is actually happening on ground. That's why we're having this conversation today. So we're going to get right into it. And I'll start with you, Dr. Bolaji. We have very strong global evidence on what saves newborn lives. However, why are these outcomes still poor, particularly in our setting, Nigeria specifically?
Okay, thank you very much for the question. You're right that we do have evidence on what can help us to lower newborn mortality. There is a lot of evidence for preterm birth. There are WHO recommendations on what could be done in terms of nutrition, in terms of kangaroo mother care, in terms of respiratory support for the newborn. There's also a lot of evidence that's been generated regarding intrapartum complications, which we would commonly refer to as perinatal asphyxia. There's a lot of work that's been done on newborn sepsis. So, these are the three leading causes of newborn mortality all over the world. But having the evidence on what works does not necessarily translate to reducing newborn mortality, especially in low and middle income countries, Nigeria being the case here. And there's been also a lot of evidence to show that a baby born in Nigeria, for example, has 11 times more the chance of dying compared to a baby born in the high-income countries. So We don't want those kind of differences. And the truth of the matter is, people here know sometimes there are multifaceted issues that we need to face that will translate into action to reduce newborn mortality. So, I mean, those are the highest tiers of healthcare provision, newborn care provision may know. But I like to say that the knowledge gap are from the primary healthcare level to the secondary healthcare level to even places that are termed tertiary healthcare level must be filled for us to have action. I mean, at the International Maternal and Newborn Health Conference a few weeks back now, I was sharing the story of a baby who was born at 33 weeks gestation was referred to our facility at Federal Teaching Hospital, Ido-Ekiti. The woman came head-on perineum, meaning that the baby was almost born, but she'd had a history of bleeding. The primary health care center that referred her as threatened abortion. I mean, how do you refer 33 weeks gestation as threatened abortion? It was good that somebody knew what to do. But if that particular case had been tackled as an abortion, nobody goes to resuscitate a baby when it's threatened abortion. Threatened abortion means common term being miscarriage. You're not expecting a baby. So you're expecting to save a mother's life. So it was good that we were able to save the baby. The baby has been discharged. Baby is fine. But we need to get the knowledge base across all the different levels: primary healthcare, secondary healthcare, and tertiary healthcare. So that's one major thing that we still need to address. But I'm sure, Doctor, there are other comments, or Dr. Aisha.
Thank you, Dr. Bolaji. I mean, there are a lot of things I want to unpack from what you have said, but just to also hear from you, Dr. Aisha, and even maybe bringing it, Dr. Bolaji has really brought it down to the reality on ground with the example that she gave. So I want to hear from you. In addition to what she has said, one thing I picked out is that initially I had assumed it's not a knowledge problem. But Dr. Bolaji has unpacked that there is still the knowledge angle to it, especially when you consider it from the different levels of care. So I'd like to hear from you, from your experience as well. What does that look like on the ground in terms of translating knowledge to actual practice?
Thank you. Just to follow up on what Dr. Bolaji has said, although there's global evidence that we are privy to, she said it that there's still a knowledge gap across the cadre. Apart from the knowledge gap, even for those that have the knowledge, we have the skill gap. There's a systemic gap. So you have people who know what to do on paper but do not have what it needs to do what they should do. So you have people who are in a tertiary center, for example, who do not have basic things to resuscitate a newborn. So even though these people have the knowledge, they can't translate it to care on the ground. Then if we take it down to the primary health care, the secondary health care, you might even find some places where they have this equipment. That's where knowledge comes in, but they have never seen it being used before. They've never been trained before. So there's that gap. There's an implementation gap as well as a knowledge gap that now translates to why we still have these high rates of neonatal mortality in Nigeria and in Africa as a whole.
Thank you very much, Dr. Aisha and Dr. Bolaji. There is a knowledge gap, just as you have mentioned. There is also the skills gap. They know theoretically, but practically now, actually getting the job done or attending to the baby, trying to save the life of the baby, there is a gap. There is clearly a gap. Right. So, Dr. Bolaji, between, the research and all of the things that we know, what do you think is currently the biggest systemic failure when it comes to newborn care?
Well, that's a good question. It's also a big question because it's hard to tie to just one thing. Dr. Aisha has talked about skills gap. But there's also the role of skills transfer. So she's a pediatrician. I'm a pediatrician. I'm a neonatologist. But what is the spectrum of people that are currently learning from me? I need to have residents in the system. I need to have senior residents. I need to have junior residents. I need to have interns. that I can transfer some of these skills to. And it's not just all about doctors. We need nursing. I mean, there are institutions that have neonatal nursing approved. There are some that where it's not even recognized. There are places that when they do finish the training, there's not better remuneration because you've gone the extra mile to learn about neonatal nursing. You're probably still just going to be paid like any other nurse in the system. There are the biomed engineers. I mean, there are the laboratory scientists, there are the nutrition scientists. So skills transfer is not just about the doctors. Doctors are important, but we work in a team. And having that team, that multidisciplinary team, is what is going to translate into us having differences in where we are. You talked about the data being at 39 per 1,000. We're one of the only countries in the world that after COVID, our neonatal indices got worse, because most countries use the resources from COVID to generally strengthen the healthcare system. But it's not exactly what we find in Nigeria. After COVID, our newborn mortality has gone to 41 per 1,000 live births, according to the NDHS data 2023. So we're exactly where we were in 1990, because that was the index, that the newborn mortality in 1990. So there are quite a number of systemic issues, like you've rightly said. There's also the issue of data, having accurate data generated from everywhere, because it's the data that we have that we project as the figures for the country. But the way it is now, many of our data, the government is trying. We are really, really trying. But there's still a lot of donor-funded, donor-driven things across the spectrum. And until we begin to take our ownership of these things and being able to say, this is our data. I know that there was a time the Ministry of Health were trying to do some, some assessment of the facilities, and to say, okay, if this is a tertiary center, is the newborn unit in that place actually tertiary? Not just functioning, are they able to deliver tertiary level care? I mean, there was a time the government was trying to do that. I'm not sure I've seen that data. It could have been done, but I've not seen it. So data generation, evidence generation at the level of national level, sub-national levels is still something we need to look into. So it's really a multifaceted thing.
Wow.
Yeah.
I've heard you talk about multidisciplinary teams. It's not just about the doctor.
No.
Everyone plays a role. I mean, it's still tying it to the knowledge and skills issue that we talked about. There was something you mentioned. You've even gone ahead, but it's important to bring it back. It's the mentorship. How is the knowledge being passed down, right? What's the sustainability in it? How do we ensure that they don't just know, but their capacity is kept consistent and it improves over time? What structures are in place? I mean, those are some things I hear you say. You also now mentioned data. We can't overemphasize the importance of data in the work that we do. I think 2 episodes ago, we talked about data. We discussed data extensively. Please, if you haven't watched that, I'll encourage you to go back and take a look at or watch the video where we discussed the benefits or the importance of data in the work that we do in this space. We're not going to deep dive into that. It provides you with all the information you need, and feel free to share and leave your comments on that. But we can't overemphasize the importance of data in newborn health as well. I mean, a lot of the time, my emphasis have been on maternal. We often forget the newborn component, right? Knowing that is part of the mother as well, right? And it's good to hear Dr. Bolaji mention that. So, Dr. Aisha, I'll just ask you. We've talked about it. Dr. Bolaji has mentioned a lot of points which I have re-echoed. But let's talk about it on ground, right? On ground, what are some of the? I know we say that there is evidence. There are processes, approaches that have been put out there that work. But on ground, let's bring it to reality. What does that look like? You can give an example. What are the evidences that currently exist, but it's not working for us right here on ground in Nigeria?
Well, thank you. To answer your question, I'll borrow from what Dr. Bolaji has said. So, on ground, I would say, for example, Like I said, I should give examples. You have a newborn at a primary health care center, for example. And because we have so many donor-funded programs, some of these primary health care centers have at least a minimum requirement for newborn resuscitation. But now you have a child that is born here, and these health workers have not been trained on how to use these things, and the child requires resuscitation. So it's going to be quite chaotic because they wouldn't really know what to do. And then we have the infrastructural problem. You were talking about systemic issues. So we have a weak referral system. Even when there's a referral, to get to wherever they're going to is another problem. So you see that we've had a lot of bottlenecks that translate to a lot of time wastage. And for the newborn, a minute is a lot of time to ensure that this child lives. So on the ground, you would see two scenarios. Either there's knowledge and there's no equipment to be used, or there is equipment to be used and knowledge or skills are absent.
Thank you, Dr. Aisha. It's really buttressing everything that has already been said, right? And adding to that and painting the picture very vividly for us. So, Dr. Bolaji, there are guidelines currently that exist for, different aspects of newborn care. How much of those guidelines are actually practicable on ground at the moment? And then, in discussing that, it's then moving on to what are the bottlenecks? We've mentioned a lot of them, right? But it's just to re-echo those things. What are the bottlenecks that prevent us from being able to translate those guidelines into real world practice? Because we're going to eventually provide solutions to them, but to hear them.
There are global guidelines, like you've rightly said, but for the country, I must say that the Federal Ministry of Health has done well. The Family Health Division, the Child Health Division, because there's a national subcommittee on newborn health. We've worked to adapt many of these global guidelines into contextual guidelines. So we have the national guideline on kangaroo mother care, which would for small and sick babies. We definitely have that. That's been recently launched. We have the national guidelines on comprehensive newborn care. It's also been launched and it's available in literally all the centers. There's a digital version. Recently, the national roadmap for newborn commodities was also launched. And these are things that will guide us in knowing that document particularly will help us to know what commodities are essential to save newborns. How much do we need? Where do we need them? What will it cost? What bundles should be put together? Because for newborn care, for instance, there's no one thing that is going to make a lot of difference. We've learned to bundle things, respiratory support, essential newborn care, sepsis intervention. So we've learned to bundle things, and the professional organizations are also doing quite a bit. The Nigerian Society of Neonatal Medicine does twice a year trainings on respiratory support, on neonatal resuscitation, and this is in an attempt to translate those guidelines into things that actually work on the ground, adapt what is the global guideline to see what can we do. People are also trying to generate evidence through research for our local context. So it's not like it's all particularly gloomy, like people are not doing anything. The Center for Newborn Health Research and Innovation to have a prominent simulation skills and simulation center where we're going to train people on the ground and translate those global evidence into local things. So we're on the path. It's just that the numbers are so high, and I'm sure with concerted effort, people working together, donor agencies, people like ACE are working to bring awareness. Government is doing its bit. There's the MAMI project, all these things. I'm sure by the time we review the data in another couple of years, we should be able to see some remarkable difference. Yeah. Thank you.
Thank you very much, Dr. Bolaji, for mentioning or for speaking about those. So, Dr. Aisha, I'd just like to ask, right? We've spoken about evidence, we've spoken about reality. and all of those bits, right? Now we're coming to solutioning, right? We've talked about the gaps, we've talked about the bottlenecks that exist, all of the challenges. We know what works. They are available. Dr. Bolaji has explained how all of these guidelines are available. The government is even working to ensure that it is adapted to the Nigerian context. All of those things are fine. We've talked about the reality. Oh, yes, there is no add up yet. We're coming up. She said the numbers are high. We're working. Everyone is working. That synergy is beginning to happen. So now we're preferring solutions, right? On the ground, maybe from the part of the healthcare workers themselves, before I go to the systemic bits, the other key, maybe state actors and the likes, just like Dr. Bolaji has mentioned, on the ground, as a health provider in the health facility, how do we make things better?
That's a very tricky question because the healthcare provider is only as good as the structure or the system that protects and supports it. So it's going to be difficult for the healthcare provider to be the one to drive the change. The drive has to come from above. And I would say that, just like Dr. Bolaji said, we have a lot of programs going on. There are a lot of things the Federal Ministry of Health is doing. So I would say if all these things are coordinated and not segregated, if we stop working in silos and make sure that we have a coordination, a central coordination that trickles from up down, we're going to begin to see more impact than we see now. What we have now is where we have several programs at several places, different places. Some people are aware of this, some aren't. So if it is coordinated and aimed into the policy, into the national working framework, then it can cascade down entirely. So basically, to answer your question, the healthcare worker's job would be to have a system that enables him or her to get the adequate training, the requisite training to try to tackle newborn care and newborn mortality, basically. So
Thank you.
it will be difficult for a single healthcare worker to make a difference.
I asked that because I have a question, but I didn't want to go straight into it to say, who is responsible? Is it the government? Is it clinicians? Is it researchers? Who is responsible for the change, right? And just like you have said, it's everybody needs to act together. There is nobody is responsible for what, but everybody being able to play their role in the grand scheme of things, being willing and available to learn. I don't want to go too deep into some of the challenges that we face on the field. You know, I mentioned that we have we've discussed the maternal bits, and more often than not, the healthcare workers that look after the mother are the ones that provide, are often, especially at the primary care level, are often the ones that provide that first or immediate care to the newborn, right? So it's availing themselves for learning. I don't want to go deep into conversations about healthcare workers' attitude to trainings and learnings and all that, but there's also a role they have to play, I believe, in availing themselves to learn, to be taught, and less around what are the benefits in it for them. And also there is still the role the government has to play. Dr. Bolaji had mentioned it, is when people take the time to learn, study, and gain the skills that they need to provide these services, there should be commensurate remuneration, or at least some form of compensation to these people. It serves as a form of encouragement. These same healthcare workers are the ones that we have the JACPA, we're experiencing JACPA syndrome and the likes. They learn and then they leave and they provide that support somewhere else. Right? Those are things that I've heard come out clearly from what you all have said. So Dr. Bolaji, I'd like to ask, if we could prioritize one thing, maybe let's look at it in two ways. If we could prioritize one thing, or if you flip it, what is the one thing that we're missing? What is the one thing that we're missing when it comes to strengthening the delivery of services for newborn health, strengthening the newborn health care system? What would we prioritize? What should we be prioritizing at this time?
I think Aisha touched on it. There has to be partnerships and collaborations. We can't work in silos and expect there to be a change. So at the level of delivering healthcare service, there needs to be partnerships where it's going to be a public partnership. If that's the model that will work there, it has to be. For research, there has to be partnerships. And partnerships not just within the country, regional partnerships. The African Neonatal Association is doing a lot to bring people together and say, hey, look, your problems are not limited to Sierra Leone alone or Nigeria alone. We have the same issues in Ghana, we have the same issues in Zimbabwe. So there has to be partnerships. There has to be partnerships in bringing the solutions that work. The biomed engineers have developed something. They must partner with the clinicians to see, look, what will work. They are the end users. When it's data, there has to be partnerships. I think the previous model of people doing things individually left a lot of uncoordinated things in its trail, and we really need to look into it again and see how do we move forward. CeNHRI is going to be doing a lot of partnership with institutions, with professional organizations, with people doing trials, with people doing quality improvement. So that coordination is being built into it. And then, of course, even within the institutions, the multidisciplinary team must be brought on strongly and reduce the inter and intra-professional rivalries that we've had in the past. That also has had a negative impact on newborn. Adults can say, look, come attend to me, I'm dying. But the baby just dies there. Nobody will say that the sample that was sent to the lab was not processed because the doctor didn't write it well. The baby just dies quietly. So we need to reduce the inter and the intra-professional rivalries. So for me, the strongest point is collaboration, partnerships across the different spheres. Thanks.
Thank you, Dr. Bolaji. That's very interesting to hear. You said something that struck me. The mother can shout, can complain, but really the child is at the mercy of whoever is attending to that child, literally at the mercy. And that's something that touched me. I don't know about every other person, but that touched me. And I think we're going to wrap this up. If we stay here, there are more and more things to unpack. But just to wrap it up, I was just thinking, we've talked about the role, the need for collaboration and synergy amongst all the key players, right? I think the question I'd ask you now is, Dr. Aisha, is currently, at what pace are we moving? Do you think that we're making progress, or are we still far behind?
Well, I think Dr. Bolaji might be well suited to answer your question, but I'll give what I think. I think we're moving, but we're not moving at the pace at which we should. And that can be improved upon, which is where CeNHRI, things like CeNHRI are going to come in and help. It's going to help us contextualize even the data locally, so that we rely less on global data and rely more on our own locally generated data that would translate more to care for us than than the global data would now. Yeah. And I think, that's it. We're moving, but it's just fragmented here and there. So by the time we coordinate and we move everything into one structure, I think we'll begin to feel more impact than we're feeling now.
Yeah. Thanks, Dr. Aisha. And Dr. Bolaji, to the last question is, you can add to that question I asked, but also just to hear from you, if you could speak to a policy leader or a government person or anybody within the sphere of influence that has much influence, right, to bring about changes in the newborn space, what is one thing you would say to them at this point in time if they were listening?
We need to move fast. and faster together. One common phrase in the global newborn space, they said it often and again at the International Maternal and Newborn Health Conference, is that we need to move faster together. We need to accelerate. 2030 is just around the corner, and we're supposed to be going to less than 12 per 1,000. We're currently at 41. So the individual numbers, I don't have them offhand, but I know some African countries need to move like 30 times faster if they want to reach that target. So there's a lot of out-of-pocket expenditure for newborns in Nigeria, and I know that the government is working hard towards the comprehensive emergency maternal obstetrical CMOC. But if they could just fast forward and make newborns completely free, so that wherever you are in this country, newborn care is free, and the mother doesn't need to think of cost. If we did that, lots of babies that are born out of facility birth, Nigeria has one of the highest out of facility births in the world. I mean, we'll reduce out of facility births, we'll reduce that time lag where babies are taken to all those funny places. They'll come to where they can access care. So if someone is listening, like, just make everything free for newborns.
All right, thank you so much, Dr. Bolaji and Dr. Aisha. A lot of insights have been unpacked here in this conversation. I'll encourage you to listen over and over again, right? Leave your comments, but this is just the start. There's so much more that we're going to discuss by the time we begin to segment these conversations. But something that Dr. Bolaji said, the newborn is at the mercy of whoever is attending to them. As a mother listening to me, you can complain. In the event that you are seeing what's happening to your child, maybe you can monitor, but more often than not, the newborn is at the mercy of the healthcare worker, be it a doctor, right, a nurse, a midwife, whoever the case, no matter how experienced they are at the mercy of the healthcare worker. So there are a lot of things that need to be in place. Systems, structures, and the people themselves. Everything needs to be in place for that newborn. And we need to move fast so we can save the lives of our babies when they are born. Thank you once again for joining us for this episode. This has been a very amazing conversation. Would like to appreciate you again, Dr. Bolaji, for joining us. Thank you for the wealth of information you've shared. Thank you, Dr. Aisha, for all of the perspective that you brought into the conversation. We really do appreciate your presence. And of course, it's not the last time. We will see you again in our next episode. Bye for now.